So everybody, I'm Jarod Roland. I'm one of the pediatric neurosurgeons here at St. Louis Children's. I did a lot of my training here, and so one of the people who trained me was Dr. Limbrick, who was a huge proponent of Chiari malformations, the treatment of Chiari malformations, and I'm pretty sure has spoken to this group a lot. But he's one of the reasons why I'm here today, and so I just wanted to kind of give him some recognition. But I just want to talk a little bit about, this was kind of the prompt I was given by Tonda, was to talk a little bit about what we know about Chiari and how we're doing some neuroimaging research to advance what we know about Chiari malformations. Okay. Disclosures or some funding. The next slide, I like this idea of having some very interactive talks. So I'm going to start off with a question. Does anybody know when we first described, or when a Chiari malformation was first described, like what year that was in? I hear some whispers. This group probably knows.
43.
Like 1943? Earlier than that.
I thought it was like in the 1890s.
Yeah.
Because I looked it up one time.
You looked it up one time. There you go. So this is always a kind of a fun, interesting way to kind of talk about what we know about Chiari, is where this kind of original description came from. It came from this gentleman named Hans Chiari. So it bears his name now. He was an Austrian pathologist. And he described this, kind of one of the ways that what he described has been described is these congenital hindbrain anomalies that ultimately took his name. A variety of these anomalies, and if you've researched Chiari malformations, you've probably seen there's kind of these numbered Chiari malformations, and then those numbers have then kind of been expanded over time. But those kind of original three, I think, came from this first publication that was in 1891. So that was a very long time ago. It was not in English. This was the kind of screenshot of his original publication title. The original publication title was About Changes in the Cerebellum as a Result of Hydrocephaly of the Cerebrum. That was kind of the Google translation. I don't know. But obviously, I was talking about a lot about this related condition of hydrocephalus. But the idea is there was a couple of these anomalies that he kind of characterized. And the other thing to notice there is he was a pathologist. He wasn't a neurologist, wasn't a neurosurgeon. He wasn't a neuroradiologist. There probably wasn't such thing as a neuroradiologist yet at that time. So a lot of his descriptions were coming from people who had passed away as he was studying their anatomy. It didn't come until much later where we got really good at imaging, where we could start describing these in living humans and figure out a lot more about this condition. But it's always interesting to kind of see where we came from, to see where we are now and where we're going in the future. So I always think that this is kind of a nice way to describe that. Most of what we'll be talking about today is what we've come to know as a Chiari malformation type 1, these type 2s and types 3s and types 4s, and these further kind of subdivisions of type 0, type 1.5, type 3.5, get very, very specific in a few other kind of categories. So we're going to talk probably about the broadest of Chiari malformation type 1. You'll sometimes see me abbreviate it as CM1 or CM type 1 or Chiari malformation type 1. But that fundamental description, as it was originally described by Hans Chiari, was the ectopic position of the tonsils of the cerebellum below the foramen magnum. So the way I usually describe this to people is the cerebellum itself is the back part of the brain. Some people will describe it the little brain, but it's this part of the brain that's back here in the back. There's a part of the skull that we will describe as the posterior fossa. That's where the cerebellum lives. And the very back part of the cerebellum has a structure that we call the tonsils. I always tell people it's the same name as the tonsils in the back of your throat. It's not the tonsils in the back of your throat, but it's the tonsils of the cerebellum. And these tonsils are in a slightly atypical position where they're extending below the foramen magnum. So the foramen magnum is the next thing you need to understand of what exactly that is. Foramen just basically means an opening in the skull. Magnum means big. It's the big opening in the base of the skull. Typically, the only thing that should be going through the foramen magnum is where the brainstem meets the spinal cord, the cervical spinal cord. So we'll sometimes call that the cervical medullary junction. But that's the only thing that is supposed to be going through that big opening in the base of the skull. Whenever the tonsils start kind of crowding their way through that big opening in the base of the skull, it's taking up space that the brainstem and the cervical spinal cord expect to occupy themselves. So when they start crowding into that region, that crowding can cause compression, and a lot of that is what contributes to all the things that we know of as a Chiari malformation. That's kind of the fundamental big picture of what that is. In the image that we have up here, I've kind of drawn this white line. Let me see if I get my little pointer. Sorry, I should have turned it on ahead of time. Yeah. So you can see this kind of white line of where that kind of imaginary foramen magnum, where that line is drawn is what the foramen magnum is. And you see this dark arrow here that's pointing to the part of the cerebellum, those tonsils, that are positioned below the foramen magnum. And that's kind of the fundamental thing that was originally described and continues to be the thing that describes Chiari malformation the most. There's a variety of other things that go along with that. We'll talk about in just a second. But there's a couple features about this condition in general that we like to think about. I'm a pediatric neurosurgeon, so I focus on pediatric patients, and one of the reasons why Chiari malformation is so important to us, to other pediatric neurosurgeons like myself, is that it has a high prevalence at young age. As Hans Chiari described, it might be because this is a congenital condition. There does seem to be times where it's not necessarily congenital. We've seen people who've had MRI scans before that did not have that at birth, and then had that, and then did develop a Chiari malformation later in life for a variety of reasons. There are times where we know what the cause is of an acquired Chiari malformation. There's times where we have no idea what the cause is of the acquired Chiari malformation. And a lot of times we're assuming that it might have been something you were born with, and it might have just become symptomatic or become recognized at some point later in life. But because of all those reasons, it has a high prevalence at young age. So pediatric neurosurgeons like myself and Dr. Straley and Dr. Limburg, who I mentioned before, see this condition a lot. There is a variety of formal testing that's been done, specifically I'm talking about kind of higher level cognitive function that we think about, that has shown significant impact from this compression at the posterior fossa here that has high impact on your higher level cognition. It doesn't seem to correlate all that well with the severity of your tonsillar ectopia. Some people have relatively mild amount of ectopia and have significant symptoms, and other people have a very significant degree of ectopia and don't have as many symptoms. There's probably some level of correlation, but it's nowhere near as tight as you might expect, because it might even make it easier if we just said if it really was as simple as a hard cutoff of 5 millimeters and it's a problem, anything less than that's not a problem. We wish it was that simple, but it's not. So that's because it's not as well correlated as we prefer. We all have been looking at different ways of defining it, different ways of things to help us predict who would benefit from treatment, and then what are the best treatments. So as we talk about treatment, there's a couple of things that we usually talk about. One is the posterior fossa decompression, or PFD is sometimes the way you'll see it abbreviated. Other people will abbreviate it as a foramen magnum decompression, or FMD, but that same concept of a decompression where those tonsils are becoming ectopic and crowding that space. The goal is to reduce that compression at the craniocervical junction, as I described before, and the way that's usually achieved is by removing some portion of the bone from the occiput, that back part of the skull, and that's called a craniectomy, and to remove usually some part of the back of the first part of the cervical lamina, or C1, and that's called a laminectomy. That combination of procedures is what we call posterior fossa decompression. It's kind of the workhorse procedure for treating a Chiari malformation. There are lots of variations there. One of the other really common things that are done is what's called a duroplasty, of not only removing some bone to remove some of that decompression, but the covering of the brain, that's called a dura, of opening that up and even sewing in a patch or some kind of graft to make that a much larger space. That duroplasty is what's diagrammed kind of up here in the C and D panel, where the dura itself is opened in a kind of a triangle shape, and you see this little patch that's sewn in to make a larger space there where there's overcrowding. A lot of variations like tonsillectomy, C1-2 fixation, a variety of other things I'm not going to go into too much detail for, but just to kind of emphasize there are a lot of variations there. As we've gotten into the modern imaging world, we no longer have to rely on diagnosing this anatomy post-mortem, but now we can use advanced imaging to diagnose these things non-invasively. So in the top right there is a kind of a diagram of that same thing I described before, and on the bottom is kind of the obviously live version of an MRI. A few other things that go along with it really frequently, things like syringomyelia or syrinx. That's in this bottom right figure. There's just a hint of this fluid collection in the cervical spinal cord, a very common pathology related to Chiari malformations. The ectopic position of the obex, that's a part of the brainstem that becomes pushed down sometimes. Again, it's kind of hard to make out here, but that's this feature of the MRI right here. Absent cisterna magna, platybasia, basilar invagination, a whole lot of other features that we've realized are associated with this ectopic position of the tonsils that was nowhere described by Hans Chiari, but as we've gotten better at our advanced imaging, have found these things to be very frequently seen together. One of the other things I like to show is this figure, where this figure shows in about 70 individuals, these were not patients, but 70 individuals, of how severe that tonsillar ectopia was. So as you can imagine, most people start to define Chiari malformations around that 5 millimeter margin. And the way that this particular study was done, it wasn't a very strict cutoff of the distance. And so you use some of those other features like the opex position, platybasia, a variety of those other things to say this is what we think of as Chiari malformation. So it wasn't a strict 5 millimeter cutoff, but it went all the way up to 3 centimeters, 30 millimeters. The reason why I like this study so much is this study specifically recruited people who were thought to be neurotypical, people who did not have a diagnosis. They're not taking any medications. They never had a diagnosis of Chiari malformation. They were thought to be, quote unquote, normal. And then they realized they have a pretty significant Chiari malformation in a lot of these individuals. And so it just kind of shows the range of that tonsillar ectopia and how it doesn't necessarily correlate with all of your symptoms. MRI imaging is one of the things that's really advanced our understanding, so I always kind of like to think again where MRI has come and to kind of show us where it's going. MRI was not around in 1891 when Hans Chiari did his original description. The original technology was described in 1971, so not too long ago. Patents were filed in 1972. The first MRI of a living human was in 1977. It was a cross-sectional image of a student's finger. That was the very first MRI that was done in 1977, so again, not too long ago. 1.5 Tesla MRIs were introduced clinically around 1980s or so, advanced to 3 Tesla MRIs in the late 90s for clinical use. And on research use, there have been 7 Tesla MRIs, which might get approved at some point in the future, and in very specific controlled research settings, things like 9.4, 10.5, 11.7 Tesla in humans. And then in animals, there's been like 21.1 Tesla, so super high resolution, really strong magnets that can look at really, really fine levels of detail. We probably don't need 21.1 Tesla MRI to show us the detail of the tonsils, but it's been a lot of advancements in MRI because we're just learning as we push the envelope, we're learning so much more. It's led to at least 2 Nobel Prizes. In 2003, it was shared, but 2 different Nobel Prizes, one in chemistry and one in medicine. Contemporary, more advanced MRI imaging, uncovering novel findings all the time. One of the things I like to talk about is moving from static imaging, where it's just a still picture, to dynamic imaging. Moving from just solid structures to now talking about movement of fluid, which I think Dr. Straley is going to talk a little bit more about. Right? Yeah. And originally we would always kind of describe about gross anatomy, and the things that I like to study a little bit more is how we relate some of that function to our structure. So this is an example of how you can have static imaging, which would be this image over on the bottom left, which is very, if you've read about Chiari malformation before, you've seen something like this of showing how the tonsils are ectopic down here. And on the right is some more dynamic imaging where you're seeing the images with the heartbeat move. And one thing I always like to show is the tonsils down here, how much they move. This is in somebody who has a Chiari malformation, and their tonsils move way more than somebody who doesn't have a Chiari malformation. They're kind of what we call hyperpulsatile. Probably contributes a lot to the symptoms that we're having from it, but have no clue about that from a typical static MRI. One of the things I like to study a lot is functional MRI. Functional MRI, there's a lot of detail here to go way off in the weeds. I'm not going to, but we're still going to talk about this thing called functional connectivity. It's a functional marker of brain activity, so not just the brain standing still, but as we're thinking, as I'm talking, my language part of my brain is doing that function. As I'm waving my hands around, those are the kind of motor areas of my brain. This image up here shows a little bit of the motor activations in the right and the left kind of motor areas of our brain. And then we figured out that even in the absence of moving my hands, just at rest, there's a lot of functional information that we can define. And that's where I like to study these things, because I like to be able to find out a lot about the networks of the brain without asking too much of my patients when they're sitting in an MRI scanner. That's a little bit about what these pictures are. Again, not going to go into too much detail, but it's a way that we've been able to parcelate the brain, the different areas of the brain, and certain functions, certain cognitive tasks that they're mostly responsible for. And the part that I like to focus on is not just where those are in a neurotypical person who doesn't have a Chiari malformation or any other neurological disease, but how those cognitive networks might become dysfunctional when something like compression of our tonsils and our craniosacral junction, whenever those things are causing us pathology. So all those things are going into a lot of study protocols, as you heard from Tanda. These are our efforts to kind of redefine Chiari malformation. We think the definition that was defined in 1891 is just not adequate in the year 2024. And so we think that a lot of these things are going to help us better define what it is, to help us better predict, to help us decide what are the best treatments, and to better predict who's going to have good outcomes from those treatments. So this was just a little bit of summary slides that Tanda mentioned earlier, that same kind of QR code that Tanda showed about some of the studies, so I'm not going to repeat that. But I do want to pause and, or maybe actually stop and see what kind of questions about any of that might be, or I could hand things over to Dr. Straley. Please.
Haven't they, I thought they quit focusing as much on the size or the millimeters of the Chiari. Do they still go by 5?
There are still a lot of people who do. Now, I think we don't put as much emphasis on that ourselves in our group, but there are a lot of people out there who still consider that a hard line in the sand, that if you're 4 millimeters, you're not Chiari malformation, and somehow magically when it's 5 millimeters, now all of a sudden it's a problem. Our group tends to think that it's probably more nuanced than that. Please.
Is it still a struggle for families to get MRIs? When we tried to get, this was 14, 15 years ago for our son Stephen, we got denied MRI imaging from the neurological board from here.
Oh, really?
And we went to 3 different doctors for his diagnosis. They kept saying, we're not going to find nothing. Is that still a struggle for families now with all this information? And, you know?
Yeah, it has gotten easier. I'm not going to say all the struggles have gone away. There are definitely times where there are barriers, whether it's from the providers, whether it's from insurance companies. There are various ways that there are still barriers. These machines are extremely big and extremely powerful, so there's actually a few safety things that go on. Every now and then, for example, one of the barriers that sometimes comes up is somebody has implants, for example. That's a big barrier, for example. Every now and then, insurance companies deny us, and they say, we don't approve it because you don't have the right symptom that they're looking for. Every now and then, there are those. But the access to MRI, you said it was about 14 years ago, access to MRI has dramatically changed over 14 years as the companies have gotten better at producing the scanners, making them a little bit cheaper, making them faster so that you're not in it as long to get as good of a quality of image, and there's overall better quality images. So the access to MRIs has gotten better. Not to say it's completely, there's a couple of obstacles, obviously, but it's gotten a lot better over the years.
That's good.
Yeah. All right. Well, thank you all for listening, and we'll kind of pass it on.